Arul Daniel also to join the live session to chair the session. Yeah, please. Along with this, please. Dr. Santosh, we are ready here.
Oh, very good afternoon. Santosh here.
Yeah.
Pradeep on stage. We can see Pradeep from here.
And Dr. Arul Daniel is also there.
Arul Daniel is okay. Welcome. So we are starting the live today with this case. I'll ask Jayendra to brief about this case.
So good afternoon, everybody. Following the hands-on workshop at Ortho-One, we are starting the next session with the live surgery, where I would like to describe the history of the patient. She is a 56-year-old female who presented to us with complaints of pain in the left knee since 10 days following a trivial injury. Clinical examination showed that there was a posteromedial joint line tenderness, McMurray positive, and terminal flexion was painful. Her X-rays were found to be normal, and the scanogram also, the alignment was okay. We did an MRI which showed a medial meniscus root tear, for which we are planned for an arthroscopic medial meniscus root repair. Thank you. Over to Dr. Bhupesh Karthik.
Section Bodanga. Bhupesh sir. Hello. Here with you, sir. Thank you. Pradeep.
Hello.
Who's
Bhupesh sir? Pradeep here.
Santosh.
Hello.
Jayendra, who is there on the other side?
Bhupesh sir, are you able to hear me?
Upesh and Arul
Hello.
Daniel.
Hello.
Can somebody hear me there? Hello.
Yeah, Bhupesh sir, we can.
Just a minute, sir.
Section ma. Section. Kamya illa.
Dr. Bhupesh, Dr. Thiru Narayanan, TNY Secretary, also is in chairing the session. He's also joined with us. Welcome, sir.
Bhupesh, good afternoon.
So in extension, it is safe. You will not damage the ACL or PCL. You can remove all these things. நான் எப்ப ரெடின்னு சொல்லுங்க நான் ஸ்டார்ட் பண்ணிக்கிறேன்.
Bhupesh, we are able to hear you now. கேக்குதா?
Yes, எனக்கு நல்லா கேக்குது.
Yes, Dr. Narayanan here. Hi, Bhupesh.
Sir, Thiru sir, hello sir.
I think next to you is Dr. Pradeep. Just say hi to Pradeep.
Praveen sir. Dr. Praveen is with me.
Okay.
Dr. Daniel, sir.
Okay.
Sir, hello sir, hello sir. I have just entered the knee. Okay.
So on the other camera in here, like
So inside view, sir?
Yeah,
Yes,
inside.
sir.
எனக்கு ஓபன் பண்ணி கொடுங்க மிஸ்டர். Relax, ரொம்ப பண்ணாதீங்க ரொம்ப. Sir, can you see the inside view?
Yes. Bhupesh sir, this is Pradeep here.
Hello, Pradeep sir. Hello.
Yeah, sir. Bhupesh sir, are you able to hear me?
Yes, well and clear.
We meet each
So-
other every weekend, I believe.
Yes. So the ACL and PCL for this patient looks okay. Sister, probe sister. Probe figure of 4. So I just entered. I'm just doing a quick diagnostic round. Lateral compartment looks pristine. There was some chondral damage in the medial side. Lateral meniscus looks okay. Now, I am just going to show one technique of how to pike rest this because we are suspecting a root tear. Can you see the outside view also? Hello?
Yeah, Dr. Bhupesh, we are able to see here, sir.
So I am just seeing this, and again, the end on view, in the view, on the view. So I am seeing the depth of the medial meniscus posterior on here. Okay? Inside, sister scope. Switching stick. And then I know this is the depth of the medial meniscus there. So I'm going to pinch my probe and then take it out. I'm going to keep a horizontal to this here, and in the side, I'm going to mark that point. Okay? எனக்கு இந்த சைடு வந்துருங்க சார், இந்த சைடு வாங்க. So I'm going to put a அது மாப் வச்சு தொடங்க மாந்தோட.
Bhupesh sir, this is the technique.
Can you see this?
This is the
Can you
technique by Bancha?
No.
No, not the other
Pancha's
one.
technique is along the TU line. This technique is not yet described. This technique will be described soon. I accidentally found it. I'll just show this. So the idea is, instead of, when you don't have light, you cannot draw too many lines. Okay, in the closed setup in the OT. So this you are just measuring with the probe, keeping a horizontal, and then the probe, and then from there 1 centimeter above, because your deep MCL is 1 centimeter there. So I'm just making one point there, mark there. Can you see that? This is the portal. I went through the, sir. This is the portal. I went with the probe. Check the depth of medial meniscus, come out, keep a switching stick or anything horizontal like this. From there, mark this point. From there, 1 centimeter above, I am making a point. Now what I am going to do is, Dr. Praveen will give me valgus force. And this is the femoral insertion of the valgus. Can you see this gradual opening?
Yeah, sir, we are able to appreciate
That's it. I got a click, and every time you get it in this first puncture. Can you see how nicely this is opened? And I have made only one puncture here. So in the view cutting, either. So the idea of doing this is, every single time we get it in first puncture, you don't have to draw fancy lines. If you want to, if your tear is here, you have to keep the probe to this level in the body, and then mark it from there and make a point. If your tear is here, you have to go feel that with the probe, feel the depth, and then mark it here. So this is a new concept, doing some cadaver studies and then writing a paper on it. So just wanted to show how easy it is to open the medial side without too much opening, isolated opening of the area that we want to see, the target area. Okay. Now the next thing that I'm going to do is plan my access routes for this. I need 2 access routes. RF foot pedal. So we can already see that there is a tear. My one access route will be for my instrument, which will be like that, along the RF. My second will be for my visualization. So I'm just going to clear the synovitis little bit here, not too much. The synovial covering of the PCL. So now my scope will come from the intercondylar notch like that. Can you see this? I will have a fantastic view like this. I can see from there, grasper, and attack from here. I can plan my reduction from here to here. So it's not easily reducing. So I'm going to do little bit of release. Blanket elevator. So I'm bringing in a small elevator, gentle, keep the opening red. Yeah. So can you see what I'm doing? I'm just elevating this gently. You should not end up doing a ramp lesion, but gently elevating this without doing chondral damage. Praveen is acknowledging what I'm doing. He's saying, yes, you're right. Thank you. Now, scoop. Next thing is to maintain biology. So although I'm going to do a transtibial technique, I will bring in my scoop and freshen this area a little bit so that healing is not a problem. Next, Shavarma.
Bhupesh sir, can you show the tear? Is it a complete tear or an incomplete tear?
Yes, in a second. This is a complete avulsion of the root. You can see the root flying out like this. Can you see that? The root is there, stuck with the posteromedial capsule.
Ah, yes, we can appreciate it now.
See that? Yeah. So this is a curved scoop. I'm making little bit of raw surface here because we are going to only put a 4.5 hole. I want some more raw surface for this to heal there. If
Bhupesh,
you are
sir,
making a 6 mm hole, then this is not enough. When you're taking out the instrument, you have to be careful, come into the notch, come through the soft tissue and take it out so that we don't do any iatrogenic insult. Yes, please tell me.
Dr. Bhupesh, I'm Dr. Daniel here.
Sir, Daniel, sir, please tell me.
How do you decide on the footprint where to make the where to curate or make to get the tunnel, sir?
Yes. So in a second, I'll just show you that. RF. So Laprade has described the footprint. Okay. Probe. Thank you, sir. So you can see the posterior rim here, sir. Daniel, sir.
Yes, sir. Yes, sir.
You can see the posterior rim,
Yes,
and
sir.
that is where the posterior rim ends.
Okay, sir.
And your fibers of PCL start from here.
Okay.
So that spot will be your
Footprint.
footprint. Can you
Okay.
see this?
Yes, sir. Very clear. Yes, sir.
This spot will be, and then I see after the release, you see the meniscus is easily sitting here.
It falls into
Initially,
place.
when we came in, we could not see this meniscus sit in well.
Correct, correct.
Okay?
Yes, sir.
So I'm going to try to keep this fellow there. That is the plan.
Okay, sir.
Okay, sir. I have the luxury of Vanita's sister helping me here. So she's, I think, the senior most sister right now in Tamil Nadu. And so I hope things will go well. If everything goes well, I'll take credit. Otherwise, we will blame it on her. Sister.
We all know about Vanita's sister. She flips the endo button from her side itself.
She's got knife with her, sir. Wonderful.
So do you always make tunnel before taking the stitch, or you take a
Sir,
stitch?
can
and
be
make
done
it?
anyway, sir. Can be done both ways.
Okay, sir.
So I think we are in the right spot. Free drill konja kodunga, sister. Free drill kodunga. Konja ulla thalli. Praveen is showing the anatomy very well, so I will just quickly go in and then make sure it is there. And as you suggested, to prevent water from coming out, maybe I will then take the bites. T button are open. I'm not happy. It's just around the corner, but I'm not sure where it is, so I'll redo it. Can you see this, sir, where I'm placing it? Yeah. Hold. Where இருக்குங்களா? bend ஆகுது. Yeah, this is perfect. Can you see that, sir? So this will happen in real life also. Once you have a miss, what you have to do is you have to do two things. You have to change the angle of the, sir, idu kattunga, sir. In the top camera kattunga. top count. So you have to change the angle. Initially I had kept it at 50 and then I could not get a good view. So now I changed it into around 55, between 50 and 55. So when you do that, you will not go in the same tunnel again and then have problems. So that is a simple trick. Sister, bite எடுத்துறலாம் sir. So next thing I'm going to do is take bites. So can you show this? Can you show this one? In the cutting. Sister, நாங்க போயிருந்தேன். So this is a new system and then sir konja neenga velila poikonga zoom pannikonga. Okay, thank you. So I like this system because you can put a stub in the top. Idu or button. So this is the button which has got a stub. Can you see the stub, sir? So this will go into the 4.5 tunnel and give you fantastic seating in the anterior tibia, and this is PEEK material. So now this has got a loop. Can you see this?
Yes, sir.
So the loop, with the loop you can do a cinch. The problem is whenever we do a cinching, you cannot put sliding knots.
Okay.
Only with regular bites you can put sliding knots, but sliding knots are superior. But here the advantage is you have one loop, then you have another loop here, and then a single thread. You can use this as a single thread or take this thread out of this sleeve. There is a bigger thread into which the smaller thread goes. You can just remove it. I'll show it when you're tying, and then make two threads, and this will slide here. In this will slide. This will slide here. So this will slide here, and then you can do a regular knot, the sliding knot. And these tapes will go with the first pass mini from Smith & Nephew. I use all companies, so this is a Sironix button, but a Smith & Nephew passer. Okay, open for me, open for me. So I'm going to come in like that. So I'm happy with this first bite. Always see the bite, yes, good bite, and then pull it out, hold. Now, outside view, top view, top view. So I'm going to take this loop, can you see this loop? Outside?
Yes, sir, yes.
This loop, and then I'm going to put this fellow into that loop. These tips are waxed, so it is easy. And then just pull him. So I have my first cinch there, okay? Second, it is color coded also. First one was white, second one is black, so there is no confusion with the sutures anywhere.
Rupesh sir, the first pass has made your job quite easy. In case
Very
the
easy.
first pass was not there, what would you have done?
So if first pass is not there, you have to use your knee scorpion, but then you have to use a 0 fiber wire and then shuttle it. Thank you, Praveen. Praveen, open. So that will be my second bite. I'm happy with the area it is taking the bite. Open, Praveen. Yes, thank you. Yeah. Open, keep it open. Yeah, hold the scope. So that is my second bite. Okay. Similarly, I'm going to take this again, put it into this loop. And then pull this, and those are my two loops. Can you see that, sir?
Yes, sir.
So now I will drill. Closed scoop on closed scoop on. Just நீங்க போய் ஸ்கோப் பிடிக்கிறீங்களா அவர் ஓபன் பண்ணி கொடுத்தோம் அங்க போய் ஸ்கோப் பிடிங்க பிரவீன் ஓபன் வை So I'll just bring in the scoop, protect it, see well, and do everything under vision. Thank you, sister. Yes. இல்ல அதுக்கு முன்னாடி ஆன்டியரா கொஞ்சம் கிளியர் பண்ணிட்டு. So I know I have come in the right spot. Can you see that, sir?
Yes, sir.
I'm just making some sure it is dilating it a little bit, small tricks, and then take it out. Now what I'm going to do next is we'll take the scope out, leave it there safely. Saline cut பண்ணிக்கோங்க. And then I'm going to top view. I'm going to dissect this properly, because once you pass sutures, you cannot dissect the soft tissues. The whole idea is 11 blade sister. The whole idea of doing this surgery will fail if we don't have proper access here when the button comes in. 15 blade first, 15 கொடுங்க.
Dr. Bhupesh, Shyam here. With your permission,
Hi,
let me
Shyam.
make an announcement. I
Yes,
request
please, yes,
the next session speakers on basic science, Dr. Linda, Dr. Elizabeth, and Dr. Ramakant to submit their presentation in the audiovisual table.
Good for subs.
Dr. Bhupesh, I have one question for you.
Yes, boss.
This is definitely a rare occurrence, but if it occurs, how to manage? Now, you have shown us a soft tissue avulsion of the meniscus root.
Yes.
How do you approach in case there is a bony avulsion of the posterior root? It is a rare occurrence, but if that happens, how are you going to manage the bites through the meniscus tissue, and what are the armamentariums that you need to have to make sure that you get a good bite?
Okay, so you can do whenever you have a bite like this. So what we have to do is, I will definitely go with this same thing because this is a big needle. The knee scorpion is a smaller needle. The smaller needles sometimes, the smaller needles we usually will not come through the bone, but this one can come through the bone. So taking big bites through it is important, but I might end, depending on the configuration, I might end up doing two tunnels. I will not be making a 4.5, maybe 2.4 tunnels on either side, so that I can fix the bone back into its bed. Like an ACL avulsion, but posteriorly. I have not seen one, but I understand that if it comes, this is how I will plan my repair. Now, I have already cleared the soft tissue here. Can you see it here? It is very important to clear the soft tissue before you bring the sutures out. This is seen nicely?
Yes, sir. Yes, sir.
Yeah. Iconics.
One more suggestion which I would like to make in case the knee scorpion or the suture passing device which you are having, if any other surgeon is not having that, previously, correct, Accupass. And another thing is previously, way back in 2013 and 14 when we were doing the meniscus root repair, what we used to do is we used to keep the tunnel exactly in line with the footprint area, and we have a long epidural needle. So that epidural needle can be used to pass through the tunnel, and we can fix it up and take nice bites to the meniscus tissue. So that was one feasibility.
Yes, definitely a nice option. Okay. Now, open. Now I have not used cannulas as you see. So I am using, thank you. So I am using this suture, this one all suture anchor from any company you can take. Can somebody see this? Show this one, outside view. Can you see this? If you don't have a lasso, this is one of the used all suture anchor. Just put a proline into the holder like this. Okay? and then put it into this. If you don't have a passing device, then switch retrievers.
Another recommendation is, if at all your working portal is difficult to manage, you can do a transpatellar portal as well. You have an extra working portal.
No, 10 minutes முடிச்சிடும் sister. பின்னாடி இல்லைங்க, பின்னாடி இல்லைங்க, பிடிச்சிட்டேன். இல்லை இல்லை, இந்த இந்த இது எடுத்துட்டு பிடிச்சிட்டேனா? பிடிச்சிட்டேன். So I'm going to other things பக்கத்தில் வச்சுக்கோங்க சார் இது. So I'm going to now do a virtual cannula. Take all these threads together. அது மூணு சேர்த்து பிடிச்சிக்கோங்க. So I'm going to take 1, 2, and 3. All these together. So all together, okay. Now can you see, because these were all in different soft tissue planes, it will usually and pull sister, pull sister, pull sister, pull. Thank you. So that's how this will reduce on. Can you see the root nicely going into its place, sir?
Yeah.
This is as anatomical as it can get. Okay? Now, if you see the pre-op MRI, there was a lot of knee down. Table light konjam up pannunga. Pidichukonga idu. Needle. Venfla needle. So I am planning a reduction stitch also. So how I am going to do that is, hold this sir, konjam pinadi pekkonga sir. Probe. First thing is, once you have seen the reduction, release it again. The meniscus should start floating again. Okay? Like that. Then bring in your anchor. Needle. This is called a mid-medial portal. Koga from Japan, he has described this well. Okay. Flex the knee, flex. Leave it down. Okay. Conjunction. 1.7 drill bit is 11 blade. Out.
Bhupesh sir, there seems to be some cartilage damage as well.
Yes.
You want to address that as well? Or?
Yeah. After the repair, we will do chondroplasty for that. There is one small area where there is full thickness cartilage loss also.
So for all cases, invariably you do a reduction stitch?
No. If you see this MRI, probe. If you see this MRI, the opening was a little more than, extrusion was a little more.
We are showing the MRI. Bhupesh.
Yeah. Can you see the MRI, the coronals?
Yes sir, we can see it now.
I cannot see what you are seeing, but.
So we'll describe it for you. The MSI is quite high.
So yes, Pradeep sir, can you just explain that to our delegates, please?
Yeah, the meniscus has extruded beyond the joint line. Actually, it's stretching the MCL. Probably there is point loading that is causing the pain. So your reduction stitch, basically, Dr. Bhupesh sir, your reduction stitch will be.
Slow up bend pannunga.
The indication is when the meniscus is completely extruded, or what do you?
Yes, when it is extruded, when I am not happy with the. When I am not happy with the reduction, too much of force. Sir, this basically will act like your medial rope. Okay, in the cuff. This makes sure all the force does not go, thank you sir, go to the root of the meniscus and the transtibial stitch. This will push the meniscus inside. and then take off the load from your posterior root.
So that there won't be any pull out of the stitches.
Exactly. Super. எடுத்துருங்க சார். நீங்க போட்டா கரெக்டா இருக்கும் சார். எடுங்க சார். வனிதா சிஸ்டர் செக்கிங்லாம் சொல்றாங்க. So this is sliding. Yes. Mini lasso. So I will now take bites anterior to this so that it will push all the soft tissue there. Saline konjam parunga. Rendu open irukka parunga. தள்ளணும் சிஸ்டர் ப்ரோலின் உள்ள. Mosquito suture retriever. அதுக்கு மேல. So I'm just going to come through that. Probe. Light source ஒன்று அப்படி தள்ளுங்க. ஒன்று கீழே தள்ளுங்க. Yes, thank you. போதும். பிடிச்சுக்கோங்க. Probe. So be gentle here. Just open, see where you want to come. Don't be in a hurry. And there, I like that spot. Push sister, push Prolin. கையிலே புஷ் பண்ணுங்க. இப்போ கையிலே புஷ் பண்ணுங்க. அது இன்ஸ்ட்ருமெண்ட் பிடிச்சாதான் தலைவலி. ஒன் Prolin.
Bhupesh sir, you are using a lasso there.
Yes, I'm using a mini lasso. Grasper. This is a mini lasso.
You could have used a nitinol loop.
Yes, can.
So you need to shuttle it through the Prolin now.
It's not a very big work. Yes, of course I can use a nitinol. It's easier. Makes life easy. Just and the owner Prolin in the load minister. Mosquito.
Bhupesh, tips for this accessory high medial portal?
Yeah, so don't make it too high, because the idea of putting this anchor is to, so can you say I have not made it too high? Initially I was starting to do it here because like bank arts, I wanted a great trajectory for this. But now I have started doing it low because I want my sutures to be extra articular. This should not stabilize the meniscus. So being a little low is actually the right thing to do. Okay? And you come close to the patella, like how you are putting your portal for your ACL missing your medial femoral condyle. Always make sure you are not too close to the medial femoral condyle to cause chondral damage. So that's my first. Mosquito. I'm going to take my second bite now. Probe. Always bring in your probe, elevate, see, and then take. Don't be in any hurry here. எதுக்குமா போதுமா? One second, I missed it once. So I can just put a knot here, like your bank arch, but that will stabilize the meniscus. Push பண்ணுங்க sister. நிமிஷம் நான் ப்ரோப் இது பிடிச்சிக்கோங்க ப்ரோப் கொடுங்க பட் தட் வில் ஸ்டெபிலைஸ் தி மெனிஸ்கஸ் இன் டு தட் ஏரியா meniscus should not be stabilized there meniscus should be free floating can you go back with the scope you're too close thank you irukku puthalunga yes good thank you so 2 bites both in the junction grasper first
Sir, is there any specific place where you want to put the anchor?
So, I want it in the body, but the bite should be anterior to it. நான் எடுத்துக்கிறேன் எது எடுக்கணும் இது வந்து ஃபர்ஸ்ட் வந்ததா இது மஸ்கிட்டோல போட்டு ஒன்றும் ஆகாது இங்கே தான் இருக்கும் எங்கே போகும் So, can you see the bites are anterior to the anchor? Then, only then this will push everything outside. அதான் ஃபர்ஸ்ட் வந்ததா This is, as I said, like your medial row anchor. This should push everything to the lateral or the posterior, and then for the stress of the posterior will be taken off. Okay, can you see there are no sutures inside? Okay?
Yes, sir, you can see it.
Even here, I am just going to withdraw this. Adu mattum odu. Yeah. Suture truth. எது வந்ததோ அது மட்டும் வச்சுக்கோங்க அதானே ஓகே அது இப்போ இது மட்டும் So I'm placing all these knots behind the எது இல்ல 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 இது வெளியில இருக்கு இங்க இருக்கு சரி நாட் ப்ரெஷர் வச்சு நான் அட்ஜஸ்ட் பண்ணி கொடுக்குறேன் So how many seconds do I have more? I'm done basically now. I'm just going to put this knot and then tie the T button in the front.
We still have time, sir. We still have 10 minutes.
Can you see how this is? Just sitting on the scope pattern. So when I put the knots, can you see how this is pushing the body in? And when I reduce this, everything will fall in place. Opening on. Straight up. Can you see this?
Yes, sir.
Now this extrusion is reduced with this knot. The extrusion is reduced with this knot. Everything is still mobile and the meniscus is pulled back in place. Sister, the arana idilunga, the black white rendu settled. Okay, I'm reducing it there. White one step. So this is going inside the tunnel that we made. Very anatomical. This is inside. You can see the amount of cartilage that is under the medial femoral condyle now. Can you see this?
Yes, sir.
It's not. So this is the centralizing anchor. When we went in, you could not see the meniscus inside like this.
Correct.
Even after this bite. But once I'm just holding the knot with the knot pusher, I still not put the knots. But once I put the knot, all this will settle down like this. Okay?
Okay, sir.
Yeah. So, sister, இது சும்மா பிடிச்சுக்கோங்க. மஸ்கிட்டோ போட்டுக்கோங்க. கடைசியா நாட் போட்டுக்கலாம். ஜஸ்ட் நான் இது போடும்போது அது ரெடியூஸ் மட்டும் பண்ணுங்க. Okay. Now leg on this. T button. ரொம்ப புஷ் பண்ணானா ரிலாக்ஸ் வச்சுக்கோங்க.
Dr. Bhupesh,
outside view வந்துக்கோங்க. Outside view கட்டுங்க. Langenbach's cutting.
Bhupesh sir, we have a question from the...
Yeah, please tell me.
Hello, Dr. Bhupesh. What is your take on removing the cartilage near the root?
So I have removed little bit because I'm making a small... I'm putting saline கூட ஆஃப் பண்ணிக்கலாம். No அவசரம் இல்லை. I'm if I do a 6 mm drill and put a suture disc, I will not be doing this. Okay, but if I am doing a 4.5 like this, then I will remove little bit of cartilage, little more medial to the footprint, because I want all that to go there and heal. Okay, so outside view, can you show this one end on? Sir, did I answer your question?
Yeah, got it.
So, in this case, I had removed the cartilage, if you had seen in the beginning. So, can you see this loop here?
Yes, sir, we can see. Yeah.
Okay. Now, there is a thread in thread. So, if I remove this one from this, can you see that?
Yes, sir.
This thread will come out of that. Can you see that? So, I have two threads now, and these two will slide. Outside view. Inside is not important. Inside cut kuda pannikonga. Outside cuttinga. Okay. Similarly, from the black, the loop is here. I am going to remove this inner loop from the outer loop. Just pull like this. Can you see this?
Yes, sir.
So once you remove, these two will slide. Okay?
Okay, sir.
Now I am going to put all this into the T button. First I will try the black. Then I will try the whites. Loading காட்டுறீங்களா? So can you see this configuration? And I am going to put this inside. Now I have good help here for showing me mosquito. Mosquito needle. And I am going to go and place this fellow right on the bone. Because it has got a stub, this will go and sit very well there. On the soft tissue.
So this button comes in different sizes, sir?
No, for root it is only this button, 4.5. Can you see how nicely this button is sitting inside? Sir, scope கூட எடுத்து வச்சிடலாம். Careful பார்த்து கவர் பண்ணிக்கோங்க. Section. எனக்கு இந்த பக்கத்துல இருந்து காட்டுங்க. இது தெரியுதா? எனக்கு இது கொடுங்க. இது விட்டுருங்க சார். இது நீங்க இல்ல. Okay.
Now it is seen, sir.
Yeah. So now what I can do is I can put a sliding knot. So இதுல வந்து ஒன்னு வந்து கீழ இவன வந்து கீழ அவன வந்து மேல அது வந்து மேல. Okay. So this fellow will press this one here. Okay. Now scope saline on பண்ணுங்க. Light source on. Okay. Mosquito. No, not pusher. அதில் போட்டுமா இல்லை ஃபர்ஸ்ட் பிளாக் போட்டுக்கலாம். அந்த இன்னொரு நாட் பீஸ் இருந்ததுல அது அதில் போட்டு அந்த கோணையா இருந்ததுல அது.
Bhupesh sir, Jayendra here.
Yeah.
The flexion angle has any significance when you put the knots, sir?
Absolutely nothing, sir. Sir, the angle of flexion is only important whenever we do a reconstruction crossing the joint. This is like fixing your proximal tibial fracture. So whenever because the intra-articular distance is variable with movement of the leg. Okay. So that is when the angle is very important when you are doing ACLs, PCLs or other type of multi-ligaments. Just out.
One more announcement. I request the medal paper presenters to assemble in Senator Hall number 1 for the best paper presentation. You can proceed to the hall right now. Thank you.
Okay. Okay. So now Anita is pushing the meniscus inside for me. Can you see that? Inside view. And Praveen is going to show me this reduction here. Praveen. And I am going to start making outside view sliding knots here. Section here. Align cut panikalam. Outside view, inside view cut panikalam. See that reduction is fantastic for the black. Can you see that reducing inside?
Yes, sir, we can see.
Yeah. Now focus on the outside view. Can you see how stable the button is? Okay, relax. I'll show the button here through the scope. Can you see how stable the button is on the align on? Can you see how stable the button is on the tibia?
Yes, sir.
You will
yes, sir.
never get this kind of lovely feel when we do the pre-endo button.
Okay.
Can you see that?
Very true, sir.
And
Yes,
I
sir.
know absolutely for sure that my stitch is going to be standing there without any trouble. Okay?
Okay, sir.
I'm just going to put a couple of knots and then I'll show you the intra-articular picture. With that, I think we are done with the surgery. Any doubts?
Good Make in India innovation.
Yes, yes. This is by Sironex, so make in India, yes, correct. And this stability, see the advantage is, it is self-cinching to start with. You don't have to cinch because there is a pre-made loop. Katarma. Then the second advantage is, it is
Bhupesh, for the benefit of delegates who are traveling or who are starting to do, they might not have access to these suture passes like Scorpion or any first pass. Any option, any other tips?
so you can see, to start with, we were doing this with Akupas. Okay, but now I think if you inform the company guys, this is easy. Now, Sham was telling a very simple way where you can have a long epidural needle and take bites through the tunnel itself. That is one more option. You actually have to be versatile, have a lot of options. Since we are in Ortho-One, I will say this out loud. We were all taught to maintain quality by DVR sir. So you cannot compromise here. On the long run, this will help you. So have proper armamentarium. It is very important, and these things are no more. I don't live in tier 1, I live in tier 3 city. We get it there, so no problem. Santosh?
Yeah, Bhupesh. And regarding rehab,
So
protocol.
because this is like a meniscal repair, she will go weight bearing for 6 weeks. And then I will avoid weight bearing in flexion alone for some time, another few weeks. As they are comfortable, they will start off doing their routine.
If you had seen the scanogram, there was very mild varus
Yes, yes.
for her on this side. The opposite side actually has more varus.
Exactly.
And that also is a chronic
Bro.
disease there. So what is your cutoff? When would you advise adding an osteotomy when there is varus?
So as we already discussed, the problem for her is in the femur here.
Yeah.
Correct?
Yeah, LDFA is.
Saline please. Inside view. Yeah. So can you just see how beautiful this is? Can you see this? This is absolutely stable. I'm trying to push with the probe and I'm not able to. Can you see this?
Yeah, that's great. That's great.
Okay. And this stability is what I like about this button. Okay. And because after doing all this, end of the day, if you're not happy with the stability that you have achieved with the final fixation, the whole thing is, and now I can show you this. So as I said, the angle is not important. You can see the white is not seen. This is perfectly cinched, absolutely stable here. Probe.
It's very beautiful.
In fact, you can't see the white anymore. Can you open gently? Yes. Oh, thank you. Can you see that? Absolutely stable. Can you see the feel? Saline varudappa. Close. Thank you, sir. So this is the final thing. You can see it running into the tunnel. Can you see that? That is exactly how I want my root repair to be when I finish. Okay? and you can see the centralizing stitch working. It has come all the way inside. I'm just going to place my knots there, and you can see the sutures are all extra-articular here. Can you see that?
Yes, sir.
And my meniscus is still mobile. That is very important. Can you see that? Meniscus is mobile. Okay? And I'll just do chondroplasty with RF, and that finishes our case. Thank you.
Thank you.
Shall I take off?
Great demonstration.
Thank you.
Thank you.
Bhupesh.
Thank you,
Thank you.
Bhupesh.
Comments from David sir. Bhupesh is expecting some comments from you.
Thank you. Thanks for that wonderful demonstration, Bhupesh sir. I thank the chairpersons for chairing this session. Thank you, Dr. Pradeep, Dr. Thirunarayanan sir, and Arul Daniel. I request Dr. Thirunarayanan sir to stay on the stage, and I request Dr. Dean Mohammed Ismail sir to come onto the stage. I take this opportunity to request Dr. David Rajan sir to felicitate the TNOA President, Dr. Dean Mohammed Ismail sir. Stage. I request Divya sir to felicitate Dr. Thirunarayanan sir as well, the TNOA Secretary. Thank you. Thank you, sir. We will quickly proceed to the next session. You want to say anything?
This meeting is being conducted under the auspices of TNOA. TNOA is doing excellent work. And thank you for coming all the way. But we really appreciate that. Thank you.
On the outset, I would like to thank sincerely our TVS sir for having invited me. And so just one request, sir. From TNOA, we are looking for a lot of articles for our JOJS. Just take this opportunity to request all the delegates here and also DVS sir to send us few articles. So we are moving towards higher indexing. So just one request. Thank you, sir.
We will proceed to the next session, which is on basic science. I request Dr. Prakash Ayadurai and Dr. Santosh Hiramath to chair the session. In addition, I would like to invite Dr. Sarthak as well to chair the session. Right. Dr. Nadraj can chair the session. We can start. The first speaker, I request Dr. Linda Will Thomas to start her talk on cartilage biology.
A very good evening to all. So today I'll be just taking you through the basics of cartilage biology and with a focus of the role of small molecules in repair and regeneration. Myself, Dr. Linda V. Thomas. I'm from the Division of Tissue Engineering and Regenerative Technologies at Sri Chitra Tirunal Institute for Medical Sciences and Technology. Cartilage, as you all know, is a dense connective tissue which is present in regions such as the ends of bones or the articular cartilage, the walls of airways, and the pinna, ear, etc. Basic functions include the cartilage is a shock-absorbing agent and sliding area for joints. It provides a smooth, glistening surface. It supports the bony tissues, and it is essential for development of growth of long bones. The characteristics are that it is semi-transparent, it tolerates mechanical stress without any permanent distortion, and it is avascular and aneural in nature. So we like to work on it because it shows a better regeneration potential. And as you all know, cartilage morphology is divided into four major zones, which includes the superficial zone, which contains or makes up almost 10% to 20% of articular cartilage thickness. And here the collagen fibers that are present in this zone is packed tightly with the chondrocytes are quite flattened in this zone. In the middle zone, it represents around 40% to 60% of the total cartilage volume. It contains proteoglycans and thicker collagen fibrils, and the collagen is organized obliquely, and chondrocytes are spherical in this zone. The deep zone represents around 30% of articular cartilage volume. It has highest proteoglycan content, and the chondrocytes are typically arranged in a columnar orientation. And the calcified zone, which is the lowest zone, which is close to the subchondral bone, it secures the cartilage to the bone by anchoring the collagen fibrils of the deep zone to the subchondral bone. The cell population is scarce here, and the chondrocytes are hypertrophic in nature. So matrix composition of cartilage is that it is enriched with water, and it consists mainly of proteoglycans and collagen. The main proteoglycan in cartilage is aggrecan, which forms the large aggregates with hyaluron and are negatively charged. And the major protein content here is the collagen type 2. If you come to the biomechanics of cartilage, when you look at it from a biomechanic point of view, cartilage is a multi-layered construct which is heterogeneous, anisotropic. It has two-phase porous structure and is viscoelastic in nature. The mechanical properties of an ideal human cartilage, the average equilibrium compression modulus ranges from 250 kilopascals to 3 megapascal. And the shear modulus is approximately around 0.2 megapascals with a hydraulic permeability of 0.7 to 1.1. This is quite important when we as basic scientists work on the development of regeneration of cartilage constructs. The articular cartilage also plays a major role in lubrication and resistance to compression during joint movement. So when you look at the basic biology of cartilage, we cannot miss out the chondrogenesis of cartilage. So cartilage basically forms from the embryonic mesenchyme in the process of chondrogenesis. And chondroblasts are the cartilage cells which happens during the period of rapid proliferation after the condensation process. And chondrocytes are cartilage cells after the period of rapid proliferation. During the embryonic development, the cartilage differentiation takes place primarily from the center outwards. And the superficial mesenchyme is what develops as the perichondrium. So basically, the perichondrium is a dense layer of fibrous connective tissue that covers the surface of most of the cartilage in the body. It consists of two layers, basically the outer fibrous layer that contains fibroblasts and collagen type 1, and inner chondrogenic layer, which adjoining the cartilage matrix contains the mesenchymal stem cells. These are a source of the new chondroplasts that divides and differentiates into the chondrocytes. So the chondroplasts actually divides in, and they provide the chondrocytes, and the fibrocartilage actually lacks the perichondrium. So the major functions are to protect the bones from injury and damage. They nourish cartilage by harboring blood supply and facilitates cartilage growth. Next is the chondroblast, which, as you all know, matures into the chondrocytes and makes up the cellular component of cartilage. And basically, the chondroblast, the function is it supports the oppositional growth or the thickening of cartilage by adding extracellular matrix to the peripheral cartilage. It differentiates into chondrocytes to regenerate cartilage upon any defect or injury. The major cells or the resident cell types in cartilage is the chondrocytes. These are highly specialized cells which vary in shape, number, and size in different zones of the cartilage tissue. The chondrocytes, however, have limited potential for replication, which contributes to the limited intrinsic healing capacity of cartilage in response to injury. Looking at the extracellular matrix of cartilage, it is, like I said, it's enriched with water. It consists mainly of proteoglycans and collagen. And the main proteoglycan in cartilage is aggrecan. And these form large aggregates with hyaluronan. The type 2 collagen is the major structural protein. Proteoglycans mainly consist of a central core protein with covalently attached carbohydrate chains called glycosaminoglycans. The hyaluron, the chondroitin sulfate, dermatan sulfate, and keratin sulfate are the GAGs which are found in the articular cartilage. Aggrecan is the major proteoglycan, and it is only found in cartilage. The aggregates contain up to 100 molecules of chondroitin sulfate, which are bound to 1 molecule of hyaluron. So the other proteoglycans that are found in the cartilage include fibronectin, biglycan, laminin, fibromodulin, and perlecan. Perlecan is actually important because it alters the proliferation and metabolism of chondrocytes in response to injury. If you look at collagen, which actually out of there are 28 different types of collagen, wherein the major types of collagen found in the cartilage are a few. I don't know why the slides are overlapping the. So basically, the collagen constitutes about 2/3 of the dry weight of the adult articular cartilage. The major type of collagen is type 2, which forms around 75% of the total fetal collagen in cartilage, and it is greater than 90% in adult cartilage. The type 11 is located in the core of the collagen type 2 fibrils, and even the type 9 is a fibril associated collagen which is involved in cross-linking the collagen network with itself and also to the non-collagenous matrix. The collagen type 10 is present around hypertrophic chondrocytes, which also helps in the underlying calcified zone of the articular cartilage. The functions of the ECM are mainly to provide mechanical integrity to the cells. The lubrication of cartilage is mainly due to a protein called lubricin. Hyaluronic acid also acts in the lubrication of chondrocytes. The proteoglycan gel trapped within the collagen meshwork enables the cartilage to resist compression. And the mechanism supplements the role played by collagen fibers, which are strong in tension but can easily fold under compression. The extracellular matrix can soak up a lot of water, and the proteoglycans are the major components wherein it stores a lot of water. There are a lot of signaling pathways, of which 4 pathways are quite important in the cartilage development, which includes the Wnt signaling pathway, which regulates chondrocyte proliferation and differentiation, the TGF-beta pathway, which regulates the expression of transcription factors and growth factors to control chondrocyte proliferation and differentiation, the FGF signaling pathway, which mediates chondrocyte development, and the Notch signaling pathway, which is vital for chondrogenesis and normal chondrocyte differentiation. So basically, if you look at the cartilage regeneration theory, 2 theories, when you look at it from the stem cell point of view, the regeneration point of view, is the stem cell differentiation theory, where the stem cells are affected by the microenvironment and directly differentiate into the chondrocytes. The paracrine theory of stem cells actually the stem cells are actually involved, like they are influenced by the microenvironment, and they secrete the derivatives, which includes growth factors or extracellular vesicles, and these allows or induces homing of endogenous stem cells, which again promotes the differentiation of these endogenous stem cells into chondrocytes. So apart from this, if you look at the regeneration theory from a healing point of view, there is a peripheral healing as well as an integral healing, which involves a cartilage to cartilage healing as well as cartilage to bone or bone to bone healing. There are also biochemical agents which are involved in cartilage regeneration, and biochemical agents are actually compounds of low molecular weights which can diffuse into the cells of diffuse into the chondrocytes to inhibit or improve a biological process. So there are 3 types of biochemical agents, which includes the growth factors, the bioactive peptides, and small molecules. The growth factors actually mediate chondrocyte differentiation from MSCs. They allow chondrocyte morphology maintenance, and they also help in cartilage matrix formation. The major growth factors involved in chondrogenesis include the fibroblast growth factor, the FGF, the TGF-beta family, the bone morphogenetic protein BMP, insulin-like growth factor, and the Wnt glycoproteins. The peptide derivatives in chondrogenesis the peptides are actually a unique class of bioactive agents which are chemically synthesized. Chemically synthesized, have better reproducibility, they are more stable as well as they are highly modifiable and have a good yield. They also help, like there are currently 2 types of peptides, which are cell-cell adhesion molecule peptides or ECM-derived peptides as well as growth factor-derived peptides. The growth factor-derived peptides include the BMP signaling-derived peptides like BMP peptide as well as the TGF-beta-derived peptide like the SPP-EPS peptide. The cell-cell adhesion molecule-derived peptide includes the N-cadherin, and the ECM components-derived peptides include the RGD sequence, the GFO, GER peptide, as well as the glycopeptides. The disadvantages of using growth factors and bioactive peptides, however, is that growth factors have low viability and short half-life, and the bioactive peptides have poor metabolic stability, poor solubility, high manufacturing cost, and rapid clearance. This is where small molecules are seen in the area of, do I have a minute?
Yeah, sure. Take.
Yeah. for cartilage tissue engineering is gaining importance in recent years. If you look at the publications, it is gaining a lot of research importance, and many scientists are actually looking at the effect of small molecules in cartilage regeneration. So basically, the advantage of small molecules, it is a low molecular weight organic compound, and it is too small to induce an immune response. It has a defined chemical structure. The biological effects are usually dose-dependent, rapid, and reversible, and it can specifically act as agonists or antagonists of intracellular signaling pathways and can precisely control stem cell differentiation. So we have two types of small molecules that are being looked upon, which are chondroprotective as well as chondroinductive. So some of these small molecules include glucosamine, salidroside, gallic acid, estrogen, berberine chloride, etc., which have several mechanisms or pathways in which they can induce or affect the chondrocyte proliferation and function. So basically here, cartogenin is one of the small molecules which have been a game changer in regenerative medicine, which is a small heterocyclic drug-like compound, and it is associated with regenerative medicine, and it has been found to induce chondrogenesis. We have done a lot of docking studies, and which we have found the docking site, which is the protein human filament A, which is the receptor onto the cell in which it binds. And it is a very small molecular weight of 317.3 gram per mole. The molecular mechanism basically is that cartogenin stimulates the chondrogenic development of MSCs through its interaction with filament A, and which is an actin binding protein. And this enables the interaction between core binding factor beta and filament A, where then the CVF beta 1 binds to RUNX1, and this activates the transcription of genes that mediates chondrogenesis. This cartogenin may also influence the TGF beta SMART pathway. So these are some of the studies that we have done on the cartogenin based study, because effects of cartogenin is dose dependent. So we have tried to conjugate these small molecules onto our gel based systems, hyaluronic acid gel based systems, and which we have used as a drug delivery system for controlled KGN release. So these are some of the results with the concentration that we have tried to standardize, looking into the GAG estimation and total collagen. And we have also looked into the gene expression of certain specific genes like SOX9 and COL2, which are giving quite promising results. So we have also stained for COL2 and aggrecan. And basically, to conclude, small molecules have the therapeutic potential in cartilage regeneration and therefore represent the next wave of regenerative engineering technique. The use of small molecules versus growth factors significantly reduces the manufacturing cost and the risk of cross-species contamination. Notably, additional clinical research is required to prove the safety and efficacy. As I know, only one clinical phase 1 trial has been done on cartogenin. And even if preclinical studies have shown encouraging results in boosting cartilage repair and regeneration, it is also critical to assess the long-term efficacy of these compounds and to take into account any possible toxicity or adverse events. So, thank you for your time.
Thank you, Dr. Linda.
Yeah.
We'll have the questions later.
Yeah, sure.
Next, we have Dr. Elizabeth to speak to us on physiology behind knee pain.
A very good afternoon. And at the outset, I would like to thank the organizing committee for this beautiful opportunity. All right. Can I start? Yeah, all right. Okay. So I will be talking about the physiology behind pain, with focus being the cartilage. So I'm sure a lot of you have heard that the articular cartilage, it is a specialized tissue which is hyaline in nature, and it plays a very pivotal role in articulation and weight bearing. But however, being relatively avascular and aneural structure, has limited self-repair, and with progression leads to pain, which is one of the symptoms for which the patients come forward for treatment. So, Dr. Linda pointed out quite in extensive manner on the ultrastructure of this cartilage. So, if you look at it, it has different layers, different orientations, different contents, which also makes it a very difficult structure to treat and repair, especially considering zonal integration. So now let's just go on to joint pain and swelling. So the thing is, it can stem from a range of symptoms. It's not only the cartilage. It's actually wrong to say it's only the cartilage that's responsible for pain, but also could be involvement of ligaments and bony structure. And so therefore it could be either due to a trauma or a non-traumatic cause which is responsible for the pain. So this is where a proper history as well as personal examination makes plays a very important role. So generally any approach for a joint pain would be first to assess if it is due to trauma. If there is an obvious mechanism of injury, say it's due to an RTA or a sports accident and has exam signs that suggest that it is a trauma like ligamentous laxity or joint deformity, then you can, yes, consider trauma and do the needful. But say the trauma is not present, then the next thing would be to look for duration. And if it is less than 6 weeks, the cause based on the symptom, what could the probable causes considering the knee joint? One, it could be septic arthritis. Considering a younger population, it could be disseminated gonococcal infection. And a young adult with throat infection having a new heart murmur, rash, or any other cause such as after rheumatic, could be contributory probably to a rheumatic or suggestive of a rheumatic fever. But if it's subacute or chronic joint pain and swelling, which lasts for 6 or more weeks, occurring in an older age cohort with joint pains and report with the typical morning stiffness symptoms, and where we do an X-ray and we get a typical picture and we are able to grade it using the KL, yes, it is a confirmation of an osteoarthritis. So although there are different causes for knee pain, let us use OA to understand the mechanism behind the knee pain, because a lot of studies have been done around OA. So osteoarthritis, it is a painful chronic disease of the synovial joint, most common form of arthritis. One must remember it's not only involves the cartilage but also structures around the cartilage, that is the bone, the ligaments, capsule, synovial membrane, as well as the periarticular muscles. And here is basically an imbalance between the repair and destruction. So if you look at, I'm just going to, I don't think I have the pointer, but then if you look at the lower portion, which is basically the purple blocks, so that's the normal cartilage, all right? And if you move on to age-related changes, you would see that the superficial zone becomes lesser, the active chondrocytes become lesser with the senescent chondrocytes becoming more, the amount of proteoglycans, collagen go down. All right. And what is the difference between age-related to the OA? There will be additional fibrillations, etc. So this is what would the major changes be in OA? You would have the chondrocytes and ECM being extensively changed, and there is apoptosis and necrosis which is being increased. So therefore you have increased anabolism, being inhibited, and boosted catabolism, leading to suppression of the ECM synthesis or its enhanced degradation. And also what would happen, and which is responsible for pain, is these deranged chondrocytes along with the synovial membrane fibroblasts start producing these inflammatory mediators. So now what has been known and what has been studied and what has actually been proved is the synovial fibroblasts. Okay, they produce a range of inflammatory cytokines that trigger the neuropeptides which activate the pain pathway. So in the priming stage, you would have these LPSs, which is basically lipopolysaccharides. They would enter into the macrophage, and I'm not going to say names because it is confusing, but just to remember a few things is the NF-kappa B pathway, which basically finally induces the NLRP3 inflammasome. There's a lot of therapy based on this targeting anti of this to therefore treat pain following whatever cause. And this finally causes release of the pro-inflammatory cytokine, which is basically IL-1 beta. That further modulates the chondrocytes to cause an increase of ADAMTS and MMP3. These are basically factors that drive synovial inflammation and cartilage degradation. So studies show that pain has a strong association with bone marrow lesions, synovitis and joint effusion, but a weak association with cartilage damage. And inflammation, we know, and lot being said, plays a pivotal role in development of OA in subsets of patient and is a major contributor to chronic pain. But however, we know that the articular cartilage is relatively avascular and neural in structure, and so therefore what actually is the source of nociception in case of osteoarthritis would be what the sources in and around the cartilage that are affected, the richly innervated joint capsule, synovium, menisci, bone, etc. So if you were to look at the categories of OA pain, they're divided into three. You have nociceptive, you have inflammatory, and you have neuropathic. So nociceptive is because there's an abnormal loading. That abnormal loading causes these mechanogated channels to open and therefore trigger the firing of the pain nerves. Neuropathic is due to damage of the nerve system per se, such as demyelination. With this kind of a pain is generally non-responsive to NSAIDs. So I'm not sure if you remember physiology, the pain fibers are mainly the A, delta, and C fibers. So I've just highlighted this. So these originate from structures in and around the joint, and they basically carry the pain sensation. So when you're looking at the OA inflammasomes, there's a huge list, just a few, just to mention. You have the CGRP, all right? So if you look at picture A, you have the substance B. These are all neuropeptides. You have important painful stimulatory factors. What that does is it binds to its respective receptors. And so this is basically, if you look, this, I'm sorry, I don't know how to use the pointer. All right. Okay, so this is basically the this is the zoom of that, all right? And so you have the A, delta, and C fibers that are arising from here, all right? So those are what carry pain. And if you remember, it goes in through the dorsal root, which is purely sensory. And the tract that takes up the pain sensation to the brain is your lateral spinothalamic tract. So pain and temperature travels through this way. So all these inflammatory factors, they upregulate and cause firing of this A delta C, and there's a lot of pathways that are activated, finally releasing the excitated neurotransmitters which excite the second order neuron which take the pain to the somatosensory cortex and therefore is perceived as pain. Just to add on another important thing that was also been recently found is that in patients who are overweight as compared to lean patients, they have additional deteriorating synovium. And if you look at the ratio of pro-inflammatory macrophages to the anti-inflammatory, there is more of it as compared to a lean patient. And if you look at the proportions of the lymphoblast cells and the myeloblast cells, they all get deranged. And therefore, there is a pathological inflammation just because of a high BMI in patients, which actually increases the preponderance for osteoarthritis and which stimulates also the inflammatory pathways. So just I'm going to end with this. What are just the drugs that therefore exploit this knowledge of targeting these various inflammasomes? There are a lot of pharmacological therapies which have reached different stages of the clinical trial. And if you look at the results, not many of them are promising. There are very few which actually show improvement in the WOMAC score or reduction in the pain. So there is still a lot of scope for work and research in the area of pain. All right. Thank you. I welcome you all to CMC. You can please visit the lab whenever you visit us in Vellore. Thank you so much.
Thank you so much, Dr. Elizabeth, for sticking on to time and for that wonderful overview. We'll now have Dr. Ramankath to speak to us about healing of cartilage.
Good afternoon, everyone. I'd like to thank Dr. Divya sir, Santosh, and Dr. Sham for giving me this opportunity. So after a basic science, I'll just touch upon how the cartilage is healed after surgical procedures, so clinical scenarios. So it is also, the cartilage repair techniques are also called as, by few people, as a biological arthroplasty. So we already know this superficial transition zone and deep zone, 4 zones of the cartilage, and the cartilage lesions evolve like from 20 to 50 years to early osteoarthritis to full-blown osteoarthritis when the pathogenesis of osteoarthritis progresses. So this is a very simple classification, ICRS classification. Just 50% is grade 2, more than 50% is grade 3, and when the subchondral bone is exposed, it should be grade 4 lesion. So the cartilage healing process of the damaged or injured cartilage tissue is repaired and restored to the normal function, and it is a tough and flexible connective tissue providing cushion for the support of the movement. And when the cartilage is damaged, the wear and tear of the disease process takes place, and the natural healings needs to repair the tissue. So it can be slow and challenging, the healing, because of the limited blood supply, and there is a hindrance of delivery of nutrients and cells for the repair. So some of the treatment options which provides this healing include a rest, which reduces the pain and inflammation. The physical therapies to strengthen the muscles around will promote the healing. The medications, of course, the pain medications to reduce the pain and inflammation, and various injections like corticosteroids or hyaluronase or biologics. And in some cases, the surgery will definitely help in the healing process. So the surgical repair, cartilage repair techniques are various kinds. The simplest one is a microfracture or the cartilage repair technique, which I'll be talking in detail. And in this presentation, we'll see how the healing happens in the microfracture, or the healing, how it happens in the mosaicplasty, or the healing in the ACI is autologous chondrocyte implantation, or with the BMAC. So the various cartilage lesions could be pathological, like osteochondritis dissecans or osteonecrosis is a subchondral bone disease, or it could be post-traumatic or comminuted fractures or a degenerative or inflammatory disease which causes the degeneration of the cartilage. So the evolution of the cartilage repair has evolved from simple microfracture to BMAC, that is bone marrow aspirate concentrate. So the smaller lesions, of course, the microfracture works. It is low cost, but it forms a patchy fibrocartilaginous tissue. And for a mosaicplasty of less than 2 centimeters square, we can use autologous plugs, which can be harvested within from the knee and then transported to the defective area. Or ACI is autologous chondrocytes for a larger lesion we can use, but ACI is a 2-stage procedure and it is expensive, whereas BMAC is a bone marrow aspirate concentrate is a single-step procedure. So we'll see how this healing happens in each of the tissue. For grade 1 and grade 2, where it is less than 50%, just abrasive chondroplasty with a shaver or a RF probe can stimulate mechanical stimulation and enhance the healing process. Whereas for the grade 4, and for the smaller lesion, we can use microfractures. Microfractures are nothing but simple punched out lesions in the subchondral bone, which brings out the pluripotent cells outside, and it forms a crimson duet kind of clot on the surface, and then the healing happens. So basically it's a perforation of subchondral plate, which brings out the stable clot formation, and it is very useful in when the lesion size is less than 2 centimeters square, and generally it doesn't work when there is a global cartilage degenerative process are there, or when there is a large area and the inflammatory regions. So it brings out the mesenchymal stem cells from the subchondral bone outside, and the fibrocartilage is formed on the surface with varying amount of deposition of various collagen content. So this is the microfracture which was done, and we can see that it kind of forms a small scar-like tissue or a fibrocartilage around it. So it's a low quality of cartilage tissue. It's not a hyaline-like cartilage, it's a fibrocartilage which forms. And what happens in a mosaicplasty or a OATS or a osteochondral transfer? It is a single stage and economical than the ACI, and it can be for less than 2 centimeters square. Where the mosaicplasty is nothing but transfer of osteochondral plug, where the cartilage cap and the subchondral bone are punched out from the donor site and then inserted into the recipient tunnels. So this is a case example, a 19-year dental student who had a OCD. The size of the lesion was 1 by 1 centimeter square. It was an unstable fragment, but subchondral bone was healthy and the vascular. So here you can see the subchondral bone is healthy, and this is a loose fragment because of OCD, osteochondritis dissecans, in this 19-year-old. So the donor plug which was taken from the non-articular portion of the patellofemoral joint. It is harvested through this donor jig, which is provided with the set, and then the plug is inserted into the recipient area after the removal of the fragment. And once it is inserted, it fits well, snugly fits without any implants. So this is the donor site, which was the recipient bone was inserted. And even this area gets covered over a period of time with a kind of a fibrocartilage. So this can be done arthroscopically and minimally invasive procedure. So this is our patient, different patient who had come for some other surgical procedure. We had an opportunity to look into his already done mosaic-plasty area. So here we can see that second look arthroscopy, the area is completely covered from where the plug was inserted. And this is the hyaline cap plug which was inserted, and then the sides are all filled up with the fibrocartilaginous tissue. And here we can see that donor area also gets covered, but of course this forms a kind of fibrocartilaginous area over that period, over that surface. So this is how it looks, the donor area and the recipient area after the mosaic-plasty. So coming to cartilage healing in autologous chondrocyte, it involves high cost, more than 3 to 4 lakhs for the surgery. It's a 2-stage procedure where tissue engineering lab is required, where the first stage we have to harvest the cartilage pieces and then send to the lab and grow it culturally and then inserted over the defect area. And but it is presumably has a better long-term outcome because it forms a hyaline-like cartilage rather than a fibrocartilage which was seen in the mosaic-plasty. But it is a 2-stage procedure and it's little technically demanding, and the other complications are also seen. So the cartilage healing in a BMAC, biological arthroplasty, where the bone marrow is aspirated, and this is a bone marrow kit which is which provides all the necessary instruments to aspirate, and then and it is spun through this machine where the bone marrow will be get separated, and then it can be collected. It separates out the RBCs, the platelet poor plasma, and the platelets, and then the separate aspirated bone marrow can be collected through the syringe like this, and then this can be kind of mixed with the cartilage scaffolds and then can be inserted into the defect area. So these are the slides from Dr. Alberto Kobe. He is known for his BMAC surgeries. So I had an opportunity to work with him. So it's from there, and these are his surgical procedure where the bone marrow aspirate is pasted onto the defect area, and it mixed with the cartilage scaffolds, and then it is sutured onto it. So these are his various patients in his clinic where BMAC was done for the cartilage defect, and this was in a 44-year tennis-old player. And we can see that he second look arthroscopy, where we can see that the bright white is the newly formed area, and that is the normal cartilage tissue. And these are the other examples, and second look arthroscopy almost looks similar to the normal hyaline-like cartilage. So the BMAC also forms the hyaline-like cartilage. These are the various examples. Here again we can see this bright white is the defect area, and these are the normal cartilage, indistinguishable, which was done for the second look arthroscopy. And MRI also shows a good integration of cartilage and iso-intense signal when compared to the other sites. So he had also done a biopsy of these cartilage, and he has found that the proteoglycan components are well organized cartilage tissues were present, and also some type 2 collagen were positive for his immunohistochemical analysis as well. So it forms the hyaline-like cartilage, and though it is not a normal hyaline cartilage, it forms a hyaline-like cartilage. So these procedures will provide, and then provides good results for the patients. So these are the various examples with various follow-up. So to know the cartilage healing, we can do a MRI and see for any edema where there was a lot of edema, and once this microfracture and then the fibrocartilage forms that goes on iso-intense lesions can be identified. This is another example of microfracture pre and post, and the mosaicplasty which was done in the ankle. We can see that the good incorporation of plug and then the iso-intense signal of black cartilage is also appreciated well in this mosaicplasty in the ankle. This is an example for mosaicplasty in the knee joint. So this is how the cartilage heals this bone marrow edema which subsides over a period of time. And the other examples for ACI as well. So the MRI evaluation is done with the MOCAD scoring based on the defect, the integrity or integrity to the borders and the surface of the repair structures, and as well, and then the scoring is done. So these are the various examples. We can know the healing of the tissues. And just this will be covered in the later lectures where PRP and other lipogems also provide some kind of cartilage healing and stimulates the enhancing by producing the growth hormones which enhances the tissue repair and the healing. So the evolution of intra-articular injections, we have started with the steroids to various visco supplements.
Dr. Makant.
Yeah, it's almost done.
Yeah.
Yeah, thank you.
Thank you so much. Thanks for that illustrative presentation, Dr. Makant. If there are any questions for the previous speakers and Dr. Makant. I have a question. Yeah. So all these cartilage repair procedures that you have done in your experience, have any one of these landed up in revision, and if so, why?
Revision, we have not had any failure of anything. So most of the patients do well.
Everything seems to work.
Yeah, some kind of fibrocartilage is produced, but only thing is there are some pain which is because of various other meniscal lesions and all those things.
Okay.
So there has not been any failure because of the surgical procedure.
How often do you do microfractures for your cases?
For most of the degenerative cases, we do microfractures only. Only if it is like contained lesions and the lesion is less than, we opt for the mosaicplasty, and if lesion is big, contained young patients, only we go for kind of ACI, okay, or BMAC.
My question is to the other speakers. Like, ma'am, how many researchers have been going now pertaining? Like, is there any good research which we should know and we can collaborate or help?
Yeah, so basically, like as a scientist, we are limited to taking any research up to the preclinical phase. But from the start, we like really want to interact with clinicians as to knowing, like I basically come for many of the ICS meetings to understand how from a clinician point of view, what are you looking at? And basically the understanding from the two sides is quite different. So we look at the basic biology, what is happening in depth, how, like for example, the other doctor had talked about the microfracture surgeries, and most of these surgeries end up with getting a fibrocartilage. It is basically because you're not looking at it from the basic biology point of view, wherein you can actually trigger the signaling pathways. This is where the role of small molecules, exosomes actually are playing a major role. So once I think if that is coming out in market, like it is a drug which can be easily marketed as a drug. It is articularly injected. This can actually enable a better regeneration of cartilage, like a hyaline-like cartilage, basically.
But there are various pharma molecules such as glucosamines, type 2 collagen, and they market it quite often to us, the clinicians. Do you think they really play a role in case of an arthritic knee or early arthritic knee? Do they really helpful?
Yes, so basically when you go in for even the quality of the cell type that is being used for each of these surgical procedures, like for example the microfracture surgeries, I would say from my point of view, is quite ideal technique, but because they are not able to contain these progenitor cells within the defect site, that is majorly why the cartilage that is being produced is fibrotic in nature. So when we go in for ACI technique, you're actually culturing these cells outside and you're taking it back to the patient. So when we do our cultures in the lab, we know that the autologous chondrocytes actually de-differentiate. So you're losing the phenotype, so, and you're placing it back into the 3D model system. But because these are healthy chondrocytes, they try to, the external environment, the microenvironment actually enables them to, revive much better. And the progenitor cells in your bone marrow are actually a mine. I would say it's a gold mine, which if triggered properly, you can actually enable a proper differentiation to a hyaline-like cartilage.
Ma'am, is there any specific environment or temperature we should maintain for which will help us in cartilage healing? Like we as sports surgeons says, ma'am, patient comes to us with knee pain,
Yes.
post-traumatic. So we know there is a chondromalacia patella, or we see on the MRIs there is cartilage hemorrhage or something. So we predominantly say ice packs, but then slowly balance when it goes chronic, we tend to say for muscular hot packs. But cartilage, do you think any point of time do they ever need hot packs, or it's always cold?
No, usually chondrocytes or even cartilage tissue, basically the cell number is quite limited. You have the cartilage is more of ECM than your cells there. So basically hot or cold, it doesn't matter. It is basically the cells, when they get stimulated to form the ECM by itself. And when do they get stimulated? It is the stiffness of the environment in which these cells are laid down. So we actually did research to find out how this stiffness actually mediates the cell differentiation. So that actually plays a major role. So when you use any gel systems, the stiffer gels actually enable a much better chondrocyte differentiation than, less stiff gels. So this is where cross-linked gels and all are playing a major role. So
Thank you, ma'am.
yeah,
Thank you.
thank you.
Yeah. Thank you, Ramaka.
Thank you. I thank all the chairpersons and speakers for a wonderful presentation. And already we delayed by almost 15 minutes now. So next, we're going to start on an orthobiologics session. I would like to welcome Dr. Mukesh Mohan and Dr. Arun Kannan to moderate this session. And even Dr. Bhupesh, you can join this orthobiologics session. Dr. Bhupesh, there. Thank you. And I'd like to invite the first speaker, Dr. Sandeep Patel. He'll be presenting about platelet-rich plasma. Yeah, thank you.
No, this is not my talk. Good afternoon, everyone. It's a pleasure to be here on a conference focused on knee. So the next couple of talks is going to be on orthobiologics, which is actually the next frontier. And it's a bridge where we can look at addressing some difficult challenges and ensure healing. So I'll be talking about platelet-rich plasma and also about superdose PRP, because we have realized that dose does matter when it comes to healing. So what is PRP? It's basically the plasma fraction of autologous blood with platelet concentration above baseline. It used to be 4 times more, but our experience, the definition is much beyond it. We have to understand the product well if we want to deliver good results. That's exactly what my talk is going to be about. So we have come up with a superdose PRP, which is for osteoarthritis knee, that is 8 ml PRP with absolute platelet number above 5 billion cells. A lot of things have changed in the last 13 years. We have been working on PRP since 2009. We have worked on all aspects, the dose, the number of injections, the need for an activator, the presence of leukocytes, ranging from animal studies to clinical trials, and we have understood what is the best PRP product when it comes to OA-knee. So the first question is, does PRP work in early OA-knee? So we were the first to establish that PRP works when we are comparing for osteoarthritis with a placebo, which is normal saline. You can see that the yellow is the normal saline where the scores are worsening, but here we have got better results, but a mild deterioration at the third follow-up. This was published in the American Journal of Sports Medicine, the first randomized controlled trial in the world. It's got more than 900 plus citations as of date. Over the last 13 years, we've got at least 25-30 publications focusing on PRP. Our findings suggest that it does work for ONE. It's a okay from our side. The question is, how does PRP work in early ONE? So we went back to the clinical trials over the last 10 years. We use a guinea pig model. It's a Duncan Hartley guinea pig. It's a spontaneous OA model. It's not a chemical-induced OA, which is how the other studies use. So this is one of our first studies where we have compared PRP with the control, and you can see that there are multiple fissures in the control group normal saline and loss of proteoglycan and patchy loss in the middle layer, in contrast to a beautiful maintenance of the structure in the PRP group. There is normal cellularity but empty lacunae and no cells. However, what is more important, especially clinically, is the anti-inflammatory properties. That best explains why your patients are happy. So in a PRP group, there is minimal inflammation, no synovial hyperplasia, but in the control group, there's more inflammation. This was published in 2015. This is another study where we have looked at immunohistochemistry. We spoke about the pathways, right? PRP has anti-apoptotic. Anti-apoptosis means apoptosis, the cells, it prolongs the cell, wherein in control group, the PRP did much better. This was with the multiple PRP injections, again published in 2019. So where multiple doses had better anti-apoptotic effect, which persisted 3 months and also till 6 months. In a guinea pig, an animal model, which lifespan is restricted, 3 months and 6 months is a big lifespan which we can equate it. That's exactly why the guinea pig model is a better model if you are looking at a spontaneous ONE which replicates human ONE. This is a recent publication published in the Indian Journal of Orthopedics a month back, where again you can see we had those beautiful lectures where they thought the caspase, so anti-apoptotic properties is there, but it also has got better anabolism profile. The aggregant, which is in the ECM matrix, is much better in a PRP group, and even the collagen 2 is much preserved in the animals where PRP was injected when compared to normal saline. So this was published last month. Well, the most important controversial trial was in 2021, October, published in JAMA. Till that day, most of the studies said that PRP works. But this was the controversial trial, the RESTORE trial, which raised eyebrows. It said that PRP does not work in comparison to normal saline. Yes, I agree with the findings of this study because the product which they used was not PRP. It is autologous conditioned plasma with merely 1.6 times concentration. It cannot be called PRP. They were injecting just plasma into it and you cannot expect results. So this randomized control trial is true. The message of this trial is that a bad PRP does not work for knee. So that's exactly, so there are, all PRP are not the same. That's exactly what we understood. We looked at understanding whether leukocyte rich is better or poor, whether we need an exogenous activator, how much, what should be the dose, whether the conventional 4 or 8 ml, and how many, a single injection, multiple injection. These are the questions which we all as clinicians have with us as to if we have a patient, what should we opt for? So there's a lot of confusion in it. The first is whether we need a leukocyte rich or leukocyte poor. We started with leukocyte poor way back, and then we have understood that it is the platelets which matter. So we cannot totally isolate the leukocytes of the PRP. If we want to capture maximum platelets in our PRP, it comes at a cost of few leukocytes. So well, the result is that both leukocyte rich and poor are effective clinically. This is what all trials say. This is what our experience on our randomized control trial have said. However, there is less side effects with leukocyte poor PRP. In a short term, it's explainable because there are no leukocytes in it, which is inflammatory. But the next groundbreaking thing which we are going to see is there's something called a granulocyte is to agranulocyte ratio. This is something good. There is a bad leukocyte, bad and a good leukocytes. The monocytes are good enough. A lot of orthobiologic products depend on monocytes and macrophages, but we don't want the neutrophils over there. So this is an area of interest as to what is an ideal PRP in terms of a gran is to gran ratio, which the study we are currently undergoing. So well, this was our 2011 study where we noted deterioration at the final follow-up, right, at 6 months compared to 3 months. This is another randomized controlled trial in 2018 where we see a continued improvement in the trend. So there was something which was improving. Over the years, we saw that our product was doing good. At the same time, so we do PRP at PGH Chandigarh with the transfusion department. We have a standard protocol, only when the patients are part of a trial. But we also get patients outside the trial when they just walk in, say, doctor, we want a PRP injection. That's where we started using the local kits available. But somehow the results with the local kits never were as good as the PRP which we were preparing it. That's exactly what led us to think what's going wrong. So then we analyzed that we have been giving 8 ml PRP with a good dose, which we call it as superdose PRP, because we feel knee is a big joint and 8 ml can be easily accumulated and it can diffuse throughout. We labeled that as superdose PRP way back in 2018. So we did a first randomized control trial, a triple blinded, to see whether this 8 ml PRP is better than a 4 ml PRP or not. It was a CTRA registered, prospective, triple blinded, randomized control trial where one group had 50 knees and the other had 49 knees. The baseline parameters were good enough. So our PRP is a double spin technique. The first spin is a 1600 RPM for 15 minutes, wherein the RBC settles down. The rest of the platelets and a WBC is taken again, and a second relatively hard spin is given where we have a platelet pellet. So it's a platelet pellet method, and then we dispense the platelet button into the 8 ml what we need. So our PRP which we are using is a leukocyte depleted PRP. It's not a leukocyte free PRP. It's neither a leukocyte rich PRP. It does have leukocytes in it. Because of that, we are able to capture most of the platelets at least 5 times above baseline and over 7. And what is important is group B, the superdose PRP had over 5 billion cells in comparison to 2.82 in the group A. We looked at WOMAC scores, Q scores, and satisfaction. You can see that in the group A it was only 28%, but in the superdose PRP, 54% change in the baseline. The similar for the WOMAC total and similar for the improvement. When patient satisfaction was evaluated, group B had 96% satisfaction. So 8 ml PRP over 5 billion, that superdose PRP, may be better than a conventional 4 ml PRP. It's published in the Orthopedic Journal of Sports Medicine 3 months back, and it's already got 10 citations, and I've had multiple correspondence to this paper from multiple authors from abroad. So the significance is that the commercially available kits give 3 to 5 ml, and the concept of superdose PRP with 8 ml challenges, and it's a big challenge to the industry. Dose does matter. There have been in vitro studies which says that more the PRP, the better is the chondrocyte culturing and all which happens. Even the older classification like Mishra and Paul never talked about the absolute numbers. We, right from 2011, have been talking about the absolute numbers. So the DEPA classification is the best, which has a section where very high dose refers to over than 5 billion. So for knee osteoarthritis, it's more than 5 billion cells which is required. The next question is whether we need an additional activator or no. So an exogenous activator is a calcium chloride or anything. The other concept is that we don't need, we just inject PRP. It comes in contact with the collagen, and that's called endogenous activator. So we used to use calcium chloride, but is there a need for activator? There was no study to actually compare a non-activator versus an activator, and ours was the first study or the randomized control trial to explore the need of an exogenous activator, and our results are that there is no need. Even if we use an activator or no activator, both are equally effective in giving good results. The next question is how many PRP injections? We started with 1, but when the study started, it was a fashion to begin with 3 injections because they compared with Hyaluron. Hyaluron that time used to be given 3 injections. So they just started off their studies randomly like, okay, let's give 3 injections and then see what happens. So our study, again, the first one, where we saw one injection was as good as two. That is, single injection was good. But remember, ours was a super dose, a high dose PRP. But then the rest of the studies in around 2014 said that at least 2 or 3 injections is better, that the multiple injections were good. So we again went back to the animal study to see whether single was good or multiple was good. In the animal study, the multiple injections did better. The anti-inflammatory effect of 3 doses were better, and in short-term chondroprotective were there with multiple injections. Again published in the American Journal of Sports Medicine in 2019. Well, so how many injections? Multiple seems to be better, but we feel that we have evolved to a superdose PRP where one is good and yearly injections may be a much better option. So again, a significance of a superdose PRP is, it's an hypothesis which again needs to be tested, because all multiple injections were a standard conventional 4 ml PRP with less dose. So could a single superdose PRP be better than multiple injections of conventional dose, which is something, a question of interest to look at it. So before concluding, this is from the January issue of the Arthroscopy Journal, where they said a greater platelet dose may yield better clinical outcomes for platelet-rich plasma in the treatment of knee OA. So now they are looking at the dose of PRP, wherein amongst the 29 studies, those studies which had PRP more than 5 billion, their PRP was effective. This is exactly what our randomized control trial, which was the first trial, that proved the same thing. So to conclude it, the editorial commentary from the Arthroscopy Journal states that a high platelet dose PRP may be the non-operative treatment of choice for knee osteoarthritis. So to conclude, PRP dose does matter when it comes to osteoarthritis. Thank you.
Thank you for your wonderful lecture. May I call upon Dr. Sarthak Patnaik for his talk on SVF-STROMAL vascular fraction.
Good afternoon, everyone. Good afternoon. So thank you, Dr. Santosh, for inviting me to Ortho-One again for the Aging Knee Conference. So when Santosh invited me for this conference and he called me up, told me to, can volume please, sorry, and gave me this conference, for me it was like entering into the research paper, looking all new things, exactly try to find out what exactly, and then one paper came which fell on me, and it really educated me some part of the stromals, what I'm going to say. So to start with, first, this is how it goes. You need to do a lot of liposuctions. You have to take help of your plastic surgeon's friend, and because I don't do this, then use the centrifuge. After a centrifuge, you separate it, remove the discard. After discarding the blood, you get all these fat tissue cells. You need to have a syringe connector. Then the fat is get emulsification of the fat has been done, and then the concentration of the plain adipose tissues has been made into 2 vials and been kept. Again, centrifugation has been done, and this is how the stromal vascular fraction change is done. So to go more on the theory part, so stromal vascular fraction is a heterogeneous mixture of cells obtained from the adipose tissues, more commonly known as the body fat. These cells include adipose-derived stem cells, the endothelial cells, the endothelial progenitor cells, the pericytes, and the therapeutic potential of SBFs is mainly attributed to the presence of adipose-derived stem cells and their ability to differentiate into various cell types such as bone cells, cartilage cells, and muscle cells. So the different components of SBF, we have the several cell types. We have the AD or the adipose-derived stem cells, in which they play a crucial role in the tissue repair, angiogenesis, and the immunomodulation. We have the endothelial progenitor cells, which plays a therapeutic potential of enhancing the blood flow and promoting tissue regeneration in the ischemic conditions. The pericytes, which the role is surrounding blood vessels, providing structural support and contributing to the vascular stability. And Their regenerative function is mostly the modulating the vascular tone, promoting angiogenesis and participating in tissue repair process. The immune cells, we have many, the macrophages, the lymphocyte and other immune cells which present in the SBF contribute to the tissue immune responses such as inflammation, irregulation and immunomodulations. So how is basically an SBF extracted? I have already shown in the video, I'll just go through, read it again. The SBF are typically obtained through fat harvest techniques, and it contains various cell types. The two main areas where the SBF and the stem cells are found, the adipose tissue and the bone marrow. The adipose tissue, to get it from the adipose tissue is a bit easier. Being a scopy surgeon, you have certain shaver blades and everything. So generally extracting the SBF cells from the adipose tissues is preferred because the area and the method of collection are more accessible, as I mentioned, and cause less discomfort in patient than extracting from the bone marrow. It is performed through a manual fat harvest using the low pressure liposuctions, usually in the abdominal area under local anesthesia. A sample of 50 cc of fat tissue is often enough for the facial aesthetics. That's what. Once harvested, the SBF with adult stem cells is separated from the fat cells, the macrophages and the additional tissue components, which are again isolated and centrifuged repeatedly to get the large tissues. So the techniques in which they can be do is the liposuction, the enzymatic excision or the centrifugation. In the centrifugation, mostly the separating the SBF, the employing centrifugation to isolate the SBF cells from the digestive tissues and other cellular debris. So there are various papers in this, one of this paper in which the ultrasound assisted isolation has been found. This is a new method to isolate the stromal vascular functions, in which they have concluded that with reduced progressing time, lower collagenous dosage and increased cell yields without impairing the viability and capacity of the SBF. The ultrasound assisted this technique, stromal isolation techniques hold the potential to emerge as a time-saving and cost-effective method for future clinical outcome applications. So therapeutic applications, in case of orthopedics setup, we have it help us in joint repair. So injecting the IVF into the damaged joints to promote cartilage regeneration and alleviate the symptoms of osteoarthritis. I have seen surgeons who have done it in stage 3. I have myself never done. But they have seen them, they're getting a result in stage 3 and stage 2 osteoarthritis. In bone healing, this is done by in my center, in my alma mater in Nagpur, in which using SVF for enhancing bone regeneration in fractures and non-union injuries. Plastic and reconstructive surgery, my colleague in Bhubaneswar, he has been using in his plastic surgery, though it's yet under study. He uses mostly for the facial aesthetics. So they believe that tissue regeneration and improve the graft visibility, which they've been using. Wound healing, chronic wounds, apply SBF to accelerate wound closure and promote tissues. Regeneration is mostly in diabetic and non-healing wounds, and also in autoimmune diseases, we can use SBF. There's another study in Tang, in which they have found out the therapeutic application of adipose-derived stromal vascular function in osteoarthritis. They have found that it's an effective treatment for repairing articular cartilage, especially for relieving the pain and other symptoms, and improving the joint function in the OA patients. One more study in which the stromal vascular fraction is regenerative reality, they have found out that it is useful in many conditions such as burn wounds, retinopathies, in cardiac conditions, mostly in the ischemic myocardium, which they have found out, and also in diabetic foot ulcers, the radiation, in case of Crohn's disease and bone regeneration. So the future prospects and challenges, the application of SBF is a potentially attractive tool for cell-based therapies. That is what I was trying to show in my first video. The studies of SBF cells are still in the infancy. However, many unsolved medical questions regarding their use as potential clinical therapies of various still remain unanswered. So it is true that even though SBF cells are one of the most accessible and therapeutically potent source of stem cells, lack of interest has resulted in little basic science and clinical data. I'll ask our sports scientists, scientists who are over here, if they can do certain studies on this, and if they can find out. I think the basic difference between us and you that we deal more with the human, human beings which are live. And for you to do any research, you don't get live human beings. It's mostly dead or animals. So that is where we can try this thing. And at last, I would like to conclude with this video. I hope I get such blessings from after seeing this video, which can help me to practice SBF. And it also gives me the courage, because being in clinical practice, taking stem cells from tummy and putting inside the knee, and to expect to get result and the patient really cooperate with me, I need such spiritual things and spiritual informations to go ahead and really shout myself, okay, I found the treatment. Thank you.
I would like to call upon Dr. Prakash Ayyadurai to speak on growth factor concentrates for osteoarthritis.
Good afternoon. Thank you so much for having me here, Ortho-One. So this is a disclaimer. So there was no AI involved in this presentation whatsoever. It's 100% human brains only. But I took the help of AI to design the first slide. So we are going to talk about an aging knee. Are we trying to reverse age? Let's find out. And I was already confused with PRP, biologics, and Sandeep comes and says, all what you're doing is nonsense. Yeah. So we need something that is, as clinicians, orthopedicians, that is very, very simple. It saves our life, saves our brains, and gives us results. So before you fall asleep, platelets really has the potential to heal. Growth factor concentrate are secreted and activated proteins which is within the platelet itself. And I think it is a simple and wise option to use these, because by harnessing the complete platelet growth potential, this growth factor concentration does not have a platelet loss. You don't have to get confused. It is completely acellular. There was leukocyte poor, rich PRP, and Sandeep is saying now agranulocyte and granulocyte poor PRP. Thanks, Sandeep, for confusing us more. And of course, there is no contamination here in growth factor concentrate, because they use a very easy protocol. Everybody can do it, and it is absolutely patient safe. The concept, we just have to, this paper was in 1986, nothing to do with growth factor concentrate. But when you look at the platelet in itself, it has all those dark spots you see there are granulocytes, and you see a microtubule, that is a cellular membrane that is forming, that is catching all these cells within. And then when you derive PRP, this is how all the clump of these platelets come together. The alpha granules, the gray matter, comes together. And then when you add an activator, now here thrombin is added, and you see in the arrows that is shown here, a lot of agranulocytes. Alpha granules gets aggregated there and probably has good potential there. So like he said, it is a same wine in different bottle, PRP, and now we know that we have one more addition to it, the granulocyte. Let's now concentrate only on this thing. This is very, very simple. I'm not going to bore you. What is a growth factor concentrate? It is a concentrated solution of growth factor. Of course, it is naturally occurring protein capable of stimulating cellular growth. There ends the matter. How does it do it? It does by cell proliferation, cellular healing, and cellular differentiation. It works, we all know this. It blocks metalloproteinosis. It regenerates ECM, like the scientist from CMC told us. ECM is more important in chondrocytes rather than chondrocytes itself. So now this is what is, it comes with the pack. So the tube has a gel, an activator, and then you collect 4 ml of patient's blood. This is always the same procedure. 4 ml of patient's blood, mix it gently, and then separate it, and then inject. Yeah, very, very simple. So collect 4 ml on an activator solution, leave it there to settle down for 30 minutes, so the cells get activated, and then you centrifuge it for 10 minutes at 304,000 RPM, and the resultant 2 ml of growth factor concentrate is relatively acellular, and it has only growth factors. And the thixotrophic gel that forms in between these cellular layers easily separates it for you to remove it off. This is how it is done, very, very simple. Anybody can do it. We don't have a technician coming from the company. Our nurses will do it. We just catch the blood in the solution, mix it gently 3 to 4 times, leave it there to settle for 30 minutes, and then centrifuge it for 10 minutes. That centrifuge for 10 minutes, and then the tube is just inverted, and the cells get separated, take and inject. Life is done, simple. So, but how does this work? Like you said, growth factor levels determine the efficacy of the platelet-rich plasma injection in a knee osteoarthritis. But are there really good growth factors in PRPs? We do not know. The company has done multiple growth factor quantification with the commercially available PRP kits, and it is 12.3x more. The P-selectin is the one that is found in the surface of the activated platelet, and it is a marker for platelet activation. They have found it 12.3% more in GFCs, and also 73.6 times more PDGF, 79.2x more VEGF, and almost 70 times more the TGF. All these are important. How many injections? Like you said, we do not know, but 3 injections is good enough in our practice, 1 month apart. How does it prove to be? It has proven to be efficacious in most of the patients. As you see, the VAS score is coming down, and you also see the Oxford knee score going up in patients with grade 2 to 3 Kellgren-Lawrence scale disease. And patients also had 1 dose, 2 dose, and 3 dose. 3 dose seems to have been doing better. Also here, you see this study has taken 31 patients. They have compared it with placebo. They have seen VAS scores, WOMAC scores, and also they have isolated the serum COL2-1 gene expression and found out the patients who got growth factor injections had less expression of COL2-1 degradation gene. Also, they have successful reduction in VAS scores and WOMAC scores. So the resultant fluid that we get comes in various colors. If it is golden yellow, it is of a desirable color, and you can gladly inject it into the patient's joint. If the resultant fluid that you get is little orange, then there is a mixture of low concentration RBC and WBC left there. It might cause an inflammatory flare. So I think it is better not to inject those type. And red, definitely not, because this can cause reactive synovitis. All this is because of poor techniques, poor centrifugation, agitation of this sample multiple times vigorously, or if you are really impatient, you let it less time for it to settle down. Also, there are other problems that you can encounter in patients with hyperlipidemia, uncontrolled diabetes, OC pills, and patients with antibiotics. That is one of my own patients with the strawberry milk color. He had higher lipid gradient, and the other one is taken immediately after the therapy. So it is relatively safe and standardized. Stability of this growth factor concentrate is also important. At room temperature, it can stay potent for 8 hours, and 4 degrees Celsius, it can stay potent for 7 days. Our experience in our hospital, we have injected around 50 patients in 8 months. Kellgren-Lawrence scale of grade 2 to 3, 3 doses. Patients have got good response. They come back to us after the first dose saying, we need that sustenance of that effect. Currently, we are also running a study on growth factors in tendon repair and ligament reconstruction, because we know that these growth factor concentrate has got some amount of all the expressed growth factors. So take home again, platelet heals, growth factor is simple and wise option, I think, because you don't have to have any confusion, and it is very easy. Thank you.
Yeah, thanks, Dr. Prakash. We next call upon Dr. Karthik Babu Natarajan for his talk on BMAC usage in OA knees. Thank you.
Good evening. So thank you to the organizers. I'm the odd one out here, so I'm the non-orthopedic doctor in the group. So let's talk on BMAC, right? So I work in a center which is multidisciplinary in Chennai. So we have orthopedicians. I'm a pain physician myself. So we specialize in musculoskeletal sports injuries and chronic pain clinic. Obviously, We are good at targeted injections, so we are trained in musculoskeletal in terms of ultrasound and fluoro-guided injections, right? Right, so to start off MSK, when we started off, our indications in orthopedics, especially in musculoskeletal, were tendinopathies, partial thickness tendon tears, partial thickness ligament tears, and osteoarthritis. We started with PRP, BMAC, and then we started with adipose. So the way we keep it is we start with, it's not like we choose the patient. So we are very interested in PRP. We do a lot of BMAC. We occasionally do adipose. We're not great fans of growth factors. So like the previous speaker said, we're not great believers in activating platelets. So we've not gone down the growth serum route, right? So since this is more a musculoskeletal clinic, so our indications other than knee were predominantly the shoulders and the ankles. So these were our indications. So we still do a lot of indications in shoulder and ankle besides osteoarthritis of the knee. Now, basically, we take a call based on the Kelly-Green-Lawrence classification. So grade 1s, we manage conservatively. Grade 4s, always go for TKRs. Anybody with deformities, varus, valgus, go for TKRs. So we have an in-house orthopedician, so it's not a big problem at all. So the area of interest is grade 2 and grade 3. So grade 2 and grade 3, we have cortisone shots, hyaluronic acid, PRP, and as pain physicians, we also do something called genicular nerve RF. So we are left with orthobiologics in terms of PRP, BMAC, and we also do genicular nerve RF. Probably I'm part of the next set of speakers where I'm talking on genicular nerve RF as well. Right. So conservative treatment, we all know, you're all very good at that. So in terms of pain procedures, I talked about 4, right? And in terms of regenerative, platelet-rich plasma, BMAC, and stromal vascular fraction. Right. So BMAC, why BMAC? Because one, we are taking it to the next level in terms of getting actual mesenchymal stem cells, autologous from the patients itself. And so in our clinic, the indications for BMAC are osteoarthritis of the knee, hip, and shoulder. We also do it for big tears in ankles, shoulders, knees, and hips. When I say big tears, partial tears, grade 2 and grade 3. We are also fond of doing BMAC in the spine. So we do a lot of intradiscal for degeneration and herniated disc, epidural, transforaminal, caudal, and cervical. We like doing BMACs in coccydynia. We also like doing BMACs in what is called as the failed back surgery syndrome. So these are our indications for BMAC. The protocol we follow is roughly about 6 times concentration. The anticoagulant of choice is ACDA, sterile swing out technique, 20 to 24 degrees, double centrifuge. And we strongly believe if you're doing PRP, we require about 10 ml of autologous blood to create good quality 1 ml of PRP. So you also know that there are some commercially available kits, like if you see the Arthrex kit or the Harvest kit for knee takes 60 ml of blood. So we strongly believe that more blood, more platelets, better outcome, right? And even though activators we use occasionally, but we're not big fans of activators. So good clinical diagnosis, confirmation of diagnosis, counsel the patient, realistically what to expect, preparation, and then do the BMAC procedure. Right, so we have been trying to do this from the anterior and the posterior iliac crest. So off late, we have almost completely switched over to the posterior iliac crest for the BMAC. So earlier, we used to do the shoulder injections of BMAC where the patient is supine in the anterior and the spine in the posterior superior iliac spine, but now we've completely shifted to the posterior superior iliac spine. So right now, this is our site of choice for taking bone marrow aspirate concentrate. And since we do it in the OT and the fluoro is always available, it's easy to do it under fluoroscope guidance. So just beside the PSIS here, so just outside the sacroiliac joint, there is usually, for people who have done a lot of BMACs, you will know that there is actually a soft spot there. So if you search properly in the PSIS, you can use fluoro guidance or ultrasound guidance. There is actually a soft spot. So actually, since I'm not an orthopedician, I don't even have a mallet in my BMAC set. So most of the time, the Jamshedi needle is entered in with the hands only, right? So this is a BMAC in the lateral iliac crest. This is BMAC in the posterior superior iliac spine. So this is our procedure of choice. And you can see that I'm using fluoroscope guidance here. And the 11 gauge Jamshedi needle is, this is your point of entry here. So this is a good point, and this is pretty easy. So depending on what you're using, you can take 40, 60, 90. I've gone as high as 120 or maybe even 160 ml for bone marrow. Remember, you have to keep rotating the needle, so you're not taking bone marrow from the same side, you're choosing it from a different side. And or you can use a multi-orifice Jamshedi needle. So usually we use a 11 gauge Jamshedi needle, which is multi-orifice, right? And yeah, so this is the point of entry. So this is fairly straightforward. You use a vacuolock syringe. This is the rotation of the BMAC itself. So I told you I don't use a mallet for this. This is a vacuolock syringe here. So this is me aspirating BMAC from the PSIS using the vacuolock syringe. And yeah, this is more BMAC, right? So roughly, if you're using for one knee, you're going to require about 40 ml of bone marrow, which you're going to use in a commercially available. So you use a nano filter. So you take out all the bony fragments here. So once this aspect of the bone marrow is done, it's pretty much like making platelet-rich plasma. Once this is done, this is pretty much like making PRP. So you use a commercially available kit, and then you do a double centrifuge. Once you have done the double centrifuge, you have PRP ready. Now, one good thing with BMAC is, other than the concentrated BMAC itself, the plasma that you get, that can be used in a lot of places. So almost always we never waste any of this. So other than the red cell which is there in the chamber, other things are used. So I use a commercially available kit. So this one here is a triple chamber kit that I'm using here. So in the second one, I've used the anticoagulated blood here. After the first centrifuge, you have red cells, you have buffy coat, you have platelet rich, platelet poor based on specific gravity. Then you lock this chamber, flip it around, and then do a second centrifuge. And then you have platelet rich here, platelet poor here, and then your red cells here, right? So this is your BMAC, and then you take it out from the cell. So usual point of entry for the knee is the suprapatellar recess. So ultrasound guided suprapatellar recess. Suprolateral approach is the procedure of choice. So we use it for chondromalacias, partial thickness ligament tears, partial thickness tendon, nothing much in the knee, and osteoarthritis. So grade 2, grade 3 is what majority we get. So this is me doing a patient's head end is here, leg end is here. This is the right knee, so this is ultrasound. So this is the patella. So this is supralateral approach of the right knee joint. We also do it intraligamentous, so we can do BMAC or PRP injections into the ACL. So if you're looking at an ACL strain, not a complete tear here, you can put two needles here and then make sure you get the ACL in contrast, and you can do intraligamentous PRP or BMAC. This is BMAC into the hip joint itself, so you can do it in the hip joint. This is intradiscal BMAC. So for disc degenerations and disc herniations, patients without foot drop, so this is a good option. We also do a lot of transforaminal, and we also do it for failed back. Little bit of endoscopic as well. Sometimes we do an endoscopic discectomy. Following that, we can do a BMAC injection. So these are my indications. So usually these patients sort of come around realistically in a time frame of around 6 weeks to 8 months. So realistically, we are looking at about 2 months of recovery here. So this is my team, and this is my take on BMAC. So thank you very much.
So any questions from the floor?
Yeah, we'll just set the ball. 1 or 2 questions.
I have a question for all the speakers. Like, you have been suggesting various modalities to treat this chronic ailment. But is there any common factor, like are they being given any oral supplements also, which was not disclosed?
Yeah. So, I mean, the bottom line to all the youngsters here is osteoarthritis needs a holistic approach. It's a multimodal management. The multimodal management has got different arms to it. Right from the patient education. For me, the most important thing is to educate the patient about what the problems are and what you're going to solve. A good rehab program, weight loss, then the exercises can be yoga as well. It's not only, we have to be open with other things as well. It could be yoga or a guided strengthening protocol. Then the supplements, so I think we have a talk on supplements. I think Dr. Santosh has planned the schedule for today so beautifully. We have an entire talk on supplements. So the role of gut biome is also coming up. So if you see actually, so it was beautifully shown in one slide where the obesity, it's not the mechanical factor itself which is going to do it. There's an inflammatory profile which is different in an obese patient inside a knee compared to a thin patient. So weight, so also the microbiome. So if you go back to the traditional sciences, we see they do the basically enemas, right? So that in a way is to alter the microbiome thing inside the gut. So these are all coming up things. But we as orthopedic clinical surgeons, we should know what is there in it, because a smart patient can come up and ask any of them. So we don't have a right answer to how things are working, but what is recommended even in AAOS guidelines is it's a multimodal management where the strength of evidence is very good for pain medications, it's very good for physical therapy, it's good for viscosupplements, good for steroids in wet joint of a knee. And I use a lot of steroids in knee, even though people say no. But again, I'm not a frequent user of steroids. It has its own indication. And then yes, PRP, it's coming up. So all the biologics, the publications to meet a grade evidence and get that to pass a AOS guidelines will take another 10 years, right? But we should be open to the idea. And when we're talking about biologics, right, we have to understand the product well. That is my message to all over here. It's not that a company guy comes, you just inject it, you know. You should know what you're injecting and the science behind it.
Dr. Sandeep and Dr. Prakash, Dr. Karthik, everybody, what we are trying to ask is, I'm just simplifying sir's question. Do you add a steroid shot with your PRP?
No.
Do you add a hyaluron with your PRP? Or do you give, after the injection, NSAIDs or oral steroids?
Yeah, so it's no oral steroids, first of all, no mixing of steroids or lignocaine with any of the biological therapies. It's not only PRP. Yes, steroids can be mixed with hyaluron. There are studies to prove it. There are products available there, which is a combination shot. So sometimes I do mix, but overall I do not. My steroid cases are totally different. It's a wet effused knee with a...
PRP and hyaluron?
PRP hyaluron we can mix, but again because I don't know how to mix in terms of, if you ask me personally, there are 3 ways where you can give this combination. One is mixing PRP and hyaluron today. The question is, if you mix both, what will happen to the visco properties of the hyaluron because of the dilution? We don't know. So for me, a better option is mix both in a graded way. Give a hyaluron shot today, followed by a visco supplement after a month, or the other way around. So there's a trial which is going on. Unfortunately, I couldn't kickstart the trial. It was an animal study. I had some regulation problem. Otherwise, I had designed study in a way where I was combining both in one. In one, it was PRP followed by hyaluron. In the third, it was hyaluron followed by PRP. Again, a lot of challenge. Which hyaluron? Low molecular weight, high molecular weight, we don't know.
Painkillers following injections?
So any part of my trial, the breakthrough painkillers, they have to mention in our follow-up at the 3rd week how many painkillers they required. So sometimes I do give them paracetamol, especially after PRP therapies, especially with the dose which I'm using. The incidence of pain and swelling is relatively more for the first 7 days, but they are all self-limiting. They do settle down. I prescribe a lot of icing for them.
Does NSAIDs after PRP injection bring down the efficacy of PRP?
I don't see a reason why it should bring it down.
So can I ask a question?
Yeah, sure, sir.
I'm Dr. Lalit Mani from Delhi. Very nice talks and a new area opening up in orthopedics. Now it appears that the indications are not clear. Yeah. So like you talked about platelet and then BMAC and then the growth factors. And can we have some clarity? Is there any clarity available that in which type of a patient a PRP is better than a BMAC or a adipose or a growth factor, or all have a common indication?
Sir, for me, I mean, it's my way of looking at a problem. So when we are talking about osteoarthritis, we are only looking at OA, right? So when we have a chondral defects or something, I am a much believer of a cellular procedures. It could be BMAC or a SVF. I need cells to fill the defect. So that's a different kettle of fish, where a surgeon's caliber is important to clear the defect, give a cellular good cells. But when we are talking about OA, we are giving injections, right? So now for me, the most important question is, does the cost justify your procedure? So there were products which came to me which were cultured stem cells which we can inject it, 1.25 lakhs. But does it actually regenerate? Can I tell my patient that it's going to regenerate his knee? It's no. So right now, cartilage regeneration for OA knee is it's still very far. We have not understand the science behind it. There are some studies recently which is telling that MRI does give some changes, but that totally depends on which cut of the MRI they are looking at it. But cellular therapies for pain relief, the most important role, whether it is even SVF, whether it is BMAC, and whether it is PRP, it is the anti-inflammatory potential, which is going to balance the anabolic and catabolic profile inside it, and the anti-inflammatory effect is going to translate in terms of patient getting relief of pain.
Thinking of
another one question,
sir,
sir.
we'll have last question,
Yeah,
sir. We'll close
last
with
question.
this. Yeah.
See, we are all talking about regeneration. So one important thing that I think everybody failed to mention is the duration of this. I think how long this regenerate is going to stay, whether this regenerate is going to degenerate again. So how long can we promise a patient, or as they say 3 months, every month injection, then after 9 months, so we have only 8 months follow-up. And another one more thing is, basic problem is, the physiologist said that cartilage is of course aneural, it is avascular, and the pain should be from the, probably somewhere around the capsule. And you regenerate you say you give BMAC, you regenerate the cartilage and you reduce the pain. Because cartilage is already, it is aneural, it's not going to give pain. So what exactly is this doing? How the pain is getting reduced? We do accept if the cartilage is formed or not, regenerate is formed or not. But the basic problem the patient came to you was pain, and you reduce the pain by giving a regenerate to the cartilage. So how long it's going to sustain, and so what is the basic physiology of reducing the pain by forming cartilage?
So the first
Sir, just rephrase the question. Just one sentence answer from maybe two of you. You give it in a grade 2 OA patient. What percentage of patients, for how long, and how much pain relief can they expect at 6 to 12 months?
My 96% is the patient satisfaction. I have follow-up till 1 year. All the trials have got follow-up till 1 year. 96% pain satisfaction. Satisfaction is the big thing what we look at end of it, right?
Okay, maybe one another panelist, maybe Dr. Karthik, you could say, Dr. Prakash, what would be your take?
Every study in literature says...
No, just with Synvisc or this hyaluronic acid, also 80 to 90% of patients are satisfied with with my experience. I have not used that much of BMAC.
We'll just get it's only an opinion. It's not a well-proven science.
Right. So the way we believe is it's mainly because the inflammation sort of settles down after you do a regenerative product. Right. So mainly we believe the pain relief is coming because the inflammation sort of settles down. That is one. Second is one of the speakers was asking about which product to use. So at this point of time, there is no clear delineation. There is overlap of regenerative products. What one physician uses PRP, the other person may use BMAC. There's nothing hard and fast. We are still not there in the guideline stage yet. Last question is, in terms of duration, roughly what we have seen is, if you use a single shot of PRP, roughly, I would say about 3 months to 6 months. And if you use a single shot of BMAC, grade 2, grade 3 OA, roughly about 1.5 years. This is what we have found in our experience. Thanks.
Thank you, sir. I think with this we'll
Thank
conclude
you.
this session.
Very, very nice discussion. I would like to